Hi, everyone. I'm Dawn Alley. I am Deputy Director of the Preventive and Population Healthcare Models Group at the Center for Medicare and Medicaid Innovation. And I am extremely pleased to see you all here after lunch and to see you at this session on population health science and public policy. I think it really says a lot about the developing Interdisciplinary Association for Population Health Science that this session and this great group of panelists is on our agenda. This is a group that is, of course, interested not only in advancing the science, but in applying it to improve population health and to inform policy. So as a person who's now in a role where I am looking to create evidence-based or at least evidence-informed or best guess policy, I am really thrilled by this group of panelists who are at the cutting edge of thinking about the really hard questions that come up when you are moving across that continuum from documenting associations to establishing causal relationships, and then thinking about where you intervene and how you develop and enact policy to improve population health. And so this is going to be a tremendous panel, a tremendous discussion. Encourage those of you on Twitter to join the conversation with the hashtag PopHealth2015, and let's go ahead and get started. I'm pleased to welcome our first panelist, Paula Lance, Associate Dean for Research and Policy Engagement and Professor of Public Policy in the Gerald R. Ford School of Public Policy at the University of Michigan. Paula is well known to many of you as a social demographer and social epidemiologist, and she's currently engaged in research regarding the potential for social impact bonds in the Medicaid program. So thanks so much, Paula.
Hi, nice to see all of you, and thanks to Michelle and Dorothy for organizing such a great meeting and for the invitation to spend a little time with you today. I was asked to talk about a recent IOM committee that I was on that put out a report on raising the age of tobacco access. So to talk a little bit about what kind of scientific process we went through on that, and then of course I'll also take a few moments to give you some of my musings on the role of research in public policy formation. And if you're interested in this topic, of course there is an IOM report on it that you can go take a look at. But so we need to back up in terms of policy a little bit. So in 2009, there was a very important landmark federal policy that was passed, the Family Smoking Prevention and Tobacco Control Act. And this itself was informed, I will say, by decades of multidisciplinary research regarding tobacco usage and tobacco control approaches. And this granted FDA the broad authority of regulating tobacco products. And there's lots of things that went into this, but it included a lot of regulatory authority regarding youth access to tobacco products. And actually this, the 2009 law set a federal minimum age of legal access, so sale or purchase of tobacco products at 18 years of age. It also, interestingly, said an FDA, you cannot come in and raise it above 18. So that's going to be the minimum age, and then also the maximum age that the FDA can do anything about. But also within this piece of legislation, there's this one line that says that the FDA needed to convene an expert panel to study, quote, the public health implications of raising the minimum age to purchase tobacco products above the age of 18 and submit a report to Congress. I don't know who reads these reports when they are legislatively demanded to go to Congress, but by March of 2015. I'm also not exactly sure about when the FDA approached the Institute of Medicine to convene the expert panel to do it, but I know when I got the invitation to serve on this panel, there was 9 months between when this was due to Congress and when the panel was convened. So we were asked to do a lot of work in a small amount of time. And here is the statement, the charge to the IOM committee. Examine the existing literature on tobacco use initiation. And I do want to underscore, there was at this time no published study on what's the impact of raising the legal age of access to tobacco above age 18. There was no empirical evidence on this at all. And so we were charged with, well, why don't you use some, magic policy simulation crystal ball kind of fancy methods of predicting the likely public health outcomes of raising the age. And we were asked to look at raising the age to age 19, age 21, and also to age 25 for the thought experiment of this. And the committee was asked not to make any policy recommendations. I am extremely relieved by that, because we had a very short amount of time, and for a committee to reach consensus, not only, well, what does the science tell us, and reach we still might be working on this. So that was okay with me. And again, at the time we were doing this, the laws varied on different states. 4 states have a minimal legal age of either purchase. The laws are written differently. Sometimes it's restricting the purchase of tobacco products. Sometimes the onus is on the seller for sale. But 4 states have ages above it, and at 19 ages, and a lot of different localities have raised the age, including, as I'm sure you all know, New York City recently passed the law. But again, we just didn't really have any good empirical data to go on. So our process, first of all, was we were supposed to, and I'm among friends, right? We were supposed, I hate to use sort of our best guess, but that's kind of what it was. So we're supposed to, if you've got a bunch of experts in the room from multiple fields, what is our best judgment about what do we think such a policy would do on initiation, defined as, and in the field it's generally defined as smoking 100 cigarettes. You're initiated into tobacco once the point you've smoked 100 cigarettes. And so we were supposed to, bringing all these experts together, what do we think would happen? And then from there, once you sort of say, okay, well, what do we think is the range of a potential impact of such a policy on smoking initiation, then we can go to some of the policy simulation models that exist out there. And we worked with 2 well-known models. So Ted Holford, who's at Yale, works with a model called Sysnet model, and David Levy, who's at Georgetown, has a model called SimSmoke model, and anyone in the tobacco control field is very familiar with these. So then we use these well-regarded models to predict, well then, once we kind of think, well, what would this policy do to initiation? The models then tell us, well, what would that then do to smoking prevalence, and then mortality, premature mortality, and all these other kinds of outcomes. Of course, if you do any of this kind of modeling, you're going to do sensitivity analyses till the cows come home, and you have to consider lots of different things. So the policy impact will depend upon enforcement. Do we think there'd be strong enforcement raising the age to 21 or 25? Are there black markets or gray markets probably more likely going to emerge? What's going to be the political backlash when you're regulating so-called adult behavior? I spent a lot of time with the brain scientists on this panel, and I have 2 sons that are in their early to mid-20s. I learned a lot about brain development and explained a lot to me about recent experiences. But anyway, what's the role of government in, infringing upon adults making choices for themselves? And, there's a lot of concern about the nanny state right now. Would there be substitution behaviors if people can't smoke? Do they use other things? So we had to consider a lot of different things. So I'm going to just quickly run through what some of the results were. And again, the conclusions about initiation, and again, I want to be really clear with you, these are the expert. This is the expert opinion of all of the different kinds of people on the panel. But a conclusion in the report is that increasing the minimal legal access age to tobacco would likely prevent or delay initiation of tobacco use, mostly by adolescents and then somewhat young adults. Excuse me. Okay. And although changes in this policy would directly pertain to individuals who are age 18 or older, we thought the largest reduction is actually going to be among adolescents age 15 to 17. And the short reason for that is you're cutting off their social sources, and that's primarily where they're getting it. And also concluded that raising the age to 21 would get you more than raising it to 19, but above 21, it's not going to make a ton of difference for lots of different reasons. And again, this is going to cut off the social sources. So the committee, with some range around this that was tested in the sensitivity models basically estimated that probably such a policy, raising it to age 21, would reduce initiation of smoking by 25% in 15 to 17-year-olds. Lots of other conclusions in the study, but that was a main one that then was tested in these models. And so then if you decrease initiation of tobacco, what does that do then on prevalence and some of these health outcomes? So of course, reducing initiation is gonna reduce prevalence of smoking. I'm gonna spare you all the gory details. That in turn, of course, if you reduce the prevalence of smoking in the population, and it's pretty well established that there are significant health risks from smoking, you're going to see effects on reducing, first of all, let's think of some maternal and child health outcomes, reducing low birth weight, preterm delivery, and SIDS deaths. And the bars on here just show the difference in the different ages. So again, when you go from 19 to 21, you get a big population level increase, because again, the committee thought the impact would be much bigger. When you go from 21 to 25, it's not going to be, there'll be some gains there, but not as much. Yes, there would be an impact on mortality as well, because again, reducing initiation, even by 25% in a narrow age range, is going to reduce mortality. Of course, there's lag effects here. The mortality results wouldn't be observed for over 30 years, but if you look at the cohort of people born between 2000 and 2019, if you put that policy in place and then they kind of went through their adolescent years, you would have about 250,000 fewer premature deaths, about 50,000 fewer deaths from lung cancer, and 4.2 million fewer years of life lost. Again, lots of other considerations. There's a whole chapter in the report. Policymakers, think about some of these outcomes, but there's many, many other things that need to be thought about. And again, we modeled this at the federal level because that's what the models do. This is not a policy that would be rolled out at the federal level. Again, the FDA is prohibited from doing this. So this is a policy where the action is going to be at the state or the local level. It's going to depend upon what's going on with other tobacco control activities. And of course, anyone who does work in tobacco control right now is, really wondering what is the increased use of e-cigarettes and other electronic nicotine delivery systems going to do in this type of behavior. Again, brain development stuff is important, and then again, worrying about shorthand, worrying about the nanny state and people's reaction to that. So thanks. The main conclusion, kind of the soundbite conclusion from the IOM committee was, in the absence of transformative changes in the tobacco market, social norms and attitudes, the epidemiology of tobacco use, the committee is reasonably confident that raising the MLA would reduce tobacco initiation, particularly among adolescents 15 to 17 years of age, and would improve health across the lifespan and would save lives. All right, so what's happened since the committee released its report? Well, lots of advocacy groups, actually, they were calling before the report even came out. Can you give us a hint? No, we can't. This is important for their strategies, but so many groups are working on this, but in particular, there's a Tobacco 21 advocacy campaign, and of course, they're waiving the IOM report. I had a slide that showed you a lot of headlines, and I took it out, but of course, the newspapers, the IOM committee recommends, or IOM committee finds evidence, or the IOM committee thinks we should do it. And again, there were no policy recommendations in here, but lots of other groups are taking, the advocacy community is taking this work and running with it. So in June of this year, Hawaii became the first state to raise the legal age to 21. There's a bill introduced in California for doing the same thing. Santa Clara County's passed an ordinance. Washington State is considering it as well. So there is, and there's lots of other local places that are considering this. And I do think we're going to see more policy action in this area. All right, so here's my musings. Again, I think we do all want evidence-based policy, evidence-informed policy, and I do think research plays a critically important role in what is a very noisy, messy, nonlinear process, the policymaking process. And research can provide information to lots of people. I think the Institute of whatever comes out of the Institute of Medicine, because of the process does have a lot of integrity, gets a lot of play and a lot of attention. And I personally think that's a good thing. But we all know too, once you start talking about policy, you cannot do that without politics introducing itself. And Albert Einstein even said that it's harder than rocket science. So those of us who do policy work feel really good about that. I want us to be stuck on that. So, there are a lot of challenges though, and we could spend a lot of time talking about that. And I think in particular, for researchers who are in academic settings, there are a lot of challenges to doing research that is actually going to matter in terms of policy discourse and make change. And lots of things to say about it. I actually have a few musings on, even thinking about the role of private industry funding. I'm running out of time, so I'll just end with a few other thoughts here. But, so here's what I think. So population health scholarship, I think, is really important. It should inform our understanding and framing of problems, because we've got to understand what a problem is before we go down any policy path. And then inform consideration of potential policy solutions, and can play an extremely important role in evaluating and understanding policy implementation, the process, and the outcomes. Are policies effective? I do think we should be responsive to the information needs of policymakers and communities and other stakeholders. And I think we should be expected and be held accountable for having an impact on population health. And if you don't agree with me on that, I would say, then why are you doing this in the first place? I think that's why we all are in this work and want to do research in the first place. We want it to be used, we want it to be made an impact, and we should hold ourselves up to that standard. As population health scientists, we need to be objective in our work, but we shouldn't conflate being objective with being neutral. Take a stand. What the research shows you about a good policy path to go down or a bad policy path to go down, that's fine. Being neutral is not the same thing as being objective. But I do think, and my good friend Jeff Levy is here, and I know we're gonna have a discussion about that. I think that a lot of people conflate the words policy and advocacy. They are not the same things. And I think where sometimes policy researchers get into trouble is when they kind of they get into the advocacy community, and that's when, and for better or for worse, that's sometimes where some messy concerns about conflict of interest come up and who your funder is. Questions about your objectivity actually can come up more when you find yourself in an advocacy role rather than one as a policy scholar who's taking a stand. So I'm out of time. But again, my thoughts are being objective is not the same as being neutral, and doing policy scholarship is not the same thing as doing advocacy. And I'm not saying don't do advocacy, I'm just saying be really careful and smart about it. I don't know if you can read that. What do we want? Evidence-based change. When do we want it? After peer review. When I first saw that, I laughed, but it made me think, do I really only want change after peer review? Actually not, because that's too slow. It's way too slow, but sort of figuring out when do we think we have enough evidence, good enough evidence, and when as researchers do we feel comfortable taking that stand and making recommendations about change, and even getting into the world of change is tough to navigate, but we're not gonna make a difference in population health unless we figure all this out, so thank you.